Hi, everyone. My name is Jessica McKernan. I work in the lung, head and neck, and CNS oncology clinics, and today I will be talking about targeted agents in non-small cell lung cancer. We'll be reviewing the mechanisms of action as well as some side effects and clinical pearls with these agents, and we will also discuss supportive care measures and management of some treatment-related toxicities. So the landscape of non-small cell lung cancer treatment has really evolved, particularly in the last 2 decades or so. You can see a lot of targeted therapy coming into play. Even within the last few years, we have seen a lot of changes and a lot of targeted therapies coming to the market. And this is because we have a variety of known targetable oncogenic driver alterations in non-small cell lung cancer, the most common being our EGFR alterations, followed by KRAS mutations. And then we have several other options as well that all constitute about less than 5% of alterations in non-small cell lung cancer. So these molecular targets are tyrosine kinase receptors that are located on the cell surface. And the mutations and fusions within these is what leads to dysregulated intracellular signaling, that leads to cancer cell proliferation or survival. So a lot of what we'll be talking about today is focused on tyrosine kinase inhibitors that attach to these different molecular targets on the cell surface. So we have a variety of targeted therapy options in non-small cell lung cancer. I won't be diving into all of these today, but wanted to provide a comprehensive list of options. There are several, like I mentioned, in the non-small cell lung space, and we will touch on some of these today. So the first is epidermal growth factor receptor, or EGFR. This is expressed on many tissues in the body, including epithelial cells, which is why we can see side effects like a rash. These are more commonly seen in non-smokers. About 90% of EGFR alterations are either exon 19 or 21. So those are the sensitizing TKI mutations. We also have less common alterations, particularly in exon 18 and 20, and these account for about 10% of EGFR positive non-small cell lung cancer. Of note, there is an acquired resistance mutation called T790M, and that can be targeted with what I consider our bread and butter agent in non-small cell lung cancer called osimertinib or Tagrisso. So this used to only be used in the metastatic space. And this has moved up into the early stages of treatment. So we now can use it in the adjuvant space in resectable non-small cell lung cancer after a platinum doublet. We also can use it in unresectable after chemo rads. A couple of notes in terms of side effects. The two biggest ones we see by far are rash and diarrhea. As I mentioned, this is the drug of choice for exon 19 or 21 mutations due to tolerance as well as good CNS penetration. Just a note about cardiac monitoring with this agent. If it is used as monotherapy, we only need to get an echo and an EKG if patients have cardiac risk factors at baseline. However, now that we are using osimertinib in combination with chemotherapy, for those patients, all patients need to get an echo at baseline because we do see increased rates of cardiomyopathy when combined with chemotherapy. Just a few clinical pearls in the EGFR space. So as I mentioned, we do have these less common alterations in exon 18 and 20. These are traditionally less sensitive to EGFR TKIs than our 19 and 21, which is considered our sensitizing alterations. Something to keep in mind, patients who have EGFR alterations generally do not respond as well to PD-1 and PD-L1 inhibitors. So immunotherapy is not the best choice in these patients. Another reason immunotherapy isn't a great option in these patients is the rate of adverse effects, particularly pneumonitis, is higher when combining with osimertinib or following. So NCCN calls out if you're using osimertinib within 3 months of immunotherapy, or if you're using them in combination, patients are at a higher risk of these pulmonary toxicities. And then just a quick note on a newer EGFR TKI called lazertinib or Lazcluze. This does not have monotherapy approval at this time. It's only approved in combination with amivantamab, which we'll talk about in a moment. But interestingly, the rates of VTE in these patients are high enough that they require VTE prophylaxis. when you start treatment and for the first 4 months. So diving in a little more into amivantamab or riprevunt, I have a picture of a butterfly here. I'm not sure if this stemmed from the way that the molecule looks on the right-hand side, but I always think of butterflies when I think of amivantamab because all of the trial names are different versions of the word butterfly. So there's chrysalis, papillon, which is French, and then mariposa, which is the Spanish word for butterfly. So this is an EGFR MET bispecific antibody. It does have activity in exon 19, 20, and 21. You can see a variety of different settings in which we use it there. The dosing is unique. It is weight-based, and we do have to use a split dose, day 1 and 2. And the reason for that is because of the increased risk of infusion-related reactions. About 2/3 of patients experience this, and rash is also very common as well. We do also see quite a bit of edema and hypoalbuminemia as well. A few pearls, we do pre-medicate all these patients with Benadryl, Tylenol, and dexamethasone. We do also a preemptive strategy for rash prevention, which we'll talk about in a moment. So these patients can experience an acneiform rash. This is an example of ways that we can manage that in the setting of amivantamab. And a lot of our EGFR inhibitors as well. So from a preventative and supportive care approach, we tell all patients to moisturize and sunscreen. We also start out up front, hydrocortisone cream and oral doxycycline for all of our patients on amivantamab. If patients experience a grade 1 reaction despite these supportive care measures, we will add topical clindamycin. For our grade 2s, we will amp up the topical steroid to medium to high potency. And if we don't see an improvement, then we start to talk about a possible dose reduction with amivantamab. For our more severe grade 3 reactions, we will add on oral steroids and throw in a derm consult. Of course, in these scenarios, we would want to hold amivantamab and wait until patients are grade 2 or better before we would resume at a reduced dose. And with our grade 4, we would discontinue. As I mentioned, a lot of these patients can experience hypersensitivity reactions. There was a recent trial that came out called the SKIPPR trial that looked at additional prophylactic strategies to reduce the incidence of infusion-related reactions to amivantamab. This included dexamethasone 8 milligrams twice a day, starting 2 days prior to the first infusion and 1 hour prior to amivantamab infusion. With this, they found that all infusion-related reactions were either a grade 1 or 2. And this decreased that infusion-related reaction rate to about 23%, which is equivalent to a 3-fold reduction in that infusion-related reaction compared to the prior standard management. We have implemented this here at UW. I do feel like anecdotally, I've seen a decreased risk of reactions. We have had some patients who have still reacted despite this. So we have been waiting for a sub-Q formulation to come out that's been in the works on the manufacturing side for quite some time and has had some barriers to come to market. So still waiting on that. Next, we have KRAS or Kristen rat sarcoma. This is a G protein with intrinsic GTPase activity. Alterations in this are often associated with our smokers. Currently, the only targetable alteration in non-small cell lung in this space is KRAS G12C. And like many of our malignancies, this is associated with a poor prognosis. Two of the KRAS inhibitors that we use in non-small cell lung cancer are sotorasib or Lumakras and adagrasib or Krazati. As you can see here, these are only used in the subsequent space. So this is not a first-line agent, but something we can use later on. A couple of call-outs here and differences between the two. So sotorasib is once a day, adagrasib is twice a day. You can see just by looking at the side effect profiles and lists here that adagrasib, generally speaking, is much more difficult to tolerate than sotorasib. A couple of other pearls and things to keep in mind when I think of drug interactions. Sotorasib, I'm always looking for patients who are on PPIs or Pepcid. The recommendation is to avoid those entirely and try to use Tums if possible for those patients. Whereas with adagrasib, it is a strong 3A4 inhibitor, so there are a lot of drug interactions. It's usually one of the first things I'm doing when I see a request come through is looking for those. Anticoagulation can also be a challenge in these patients because there are a lot of drug interactions with those. And then the other thing to call out here with sotorasib, it does have a shorter half-life, whereas adagrasib has a longer half-life. So it's kind of nice for patients who were more worried about tolerance. Sotorasib generally better tolerated and also kind of a faster on-off. So that's a nice option. One other thing to call out is adagrasib does have more robust data in terms of CNS penetration, but we still have data for sotorasib, and that would be a fine option as well. Next, we have ALK, or anaplastic lymphoma kinase. There is a novel fusion oncogene called EML4 ALK in non-small cell lung cancer. We often see this in our younger patients and never smokers. And again, similar to our EGFR, exon 19 and 20 alterations, this also confers less benefit from our immunotherapy. So two of the more common ALK inhibitors that we use in non-small cell lung cancer include alectinib or Alecensa and lorlatinib or Lorbrena. Just a quick call out here in terms of indication, the only ALK inhibitor that's approved in earlier stage non-small cell lung cancer as adjuvant therapy is alectinib. You can see alectinib is twice a day, lorlatinib is once a day. In terms of side effects with alectinib, the most common side effect we see is fatigue, but otherwise generally pretty well tolerated. With lorlatinib, it does have some unique effects. Things that I've seen patients really struggle with are CNS effects. We do see in almost all of our patients an elevation in lipids, so we have to monitor that closely as well. Both of these agents do have good CNS penetration, and lorlatinib also overcomes known ALK resistance mutations. In terms of lorlatinib-induced hyperlipidemia, so like I said, essentially all of our patients will have some level of elevation of their lipids while they are on this agent. And I think the key call-outs here is that we have a low threshold to start lipid-lowering therapy. So if they have mild elevations, we normally get that on board pretty early on, just because we know that this is something they can struggle with throughout treatment. Lorlatinib does interact with a variety of statins, so there is no interaction with rosuvastatin, so oftentimes we're starting rosuvastatin 5 milligrams in these patients. And then the other call out in this slide that I wanted to mention is that there is a very high threshold for holding lorlatinib. You really don't need to hold or modify lorlatinib in any way until you get to the much more severe or even life-threatening elevations in these lipids. I also wanted to call out, there's been some interesting data that's come out over the last few years about alternative dosing strategies for some of these agents. So there was a trial that was mandated at the time of accelerated approval of sotorasib that compared the currently FDA approved dose of 960 to 240 milligrams. And that demonstrated an incidence of at least grade 3 treatment-related adverse events that was higher with the 960 compared to the 240. And there was no statistically or clinically significant improvements in median progression-free survival or overall survival. And you can see that there's quite a big cost difference between the two dosing strategies as well. So the way that we've applied this in practice is for our patients who we are worried about tolerance, we aren't too concerned about starting a lower dose and kind of working our way up based off of their tolerance levels and how they respond. And then there was recent post hoc analysis that came out with the CROWN trial for lorlatinib that looked at patients who had a lorlatinib dose reduction within the first 16 weeks compared to those who did not. And this did not seem to impact median progression-free survival or time to intracranial progression. So what we have adopted at UW is we now start all of our patients at 75 milligrams once a day instead of 100 milligrams once a day. Next, we have our ROS1 or ROS proto-oncogene 1. Again, this is a receptor tyrosine kinase, and we can see both fusions and rearrangements in non-small cell lung cancer that lead to constitutive kinase activity. We do see alterations in this space more often in our younger females and never smokers. So two of the more common ROS1 inhibitors that we use are entrectinib or Rozlytrek and repotrectinib or Augtyro. Just to call out with the dosing with repotrectinib, there is a titration schedule. So it's given once a day for 2 weeks, and then it is increased to twice a day. When I think of ROS1 inhibitors, generally I think that they can be pretty difficult to tolerate. And we can also see quite a bit of neurotoxicity, including cognitive impairment and dizziness. We have also seen quite a bit of edema with entrectinib in particular, as well as cardiac effects as well. And then with repotrectinib, we can use this in patients who previously received a ROS1 TKI because it has shown activity against resistance mutations. Next, we have MET, or mesenchymal epithelial transition factor. In non-small cell lung, we can see MET amplification, and we can also see MET exon 14 skipping mutations. These are more often seen in our older women and never smokers. Two MET inhibitors that we use in non-small cell lung include capmatinib or Tabrecta and tepotinib or tepmetko. A few callouts and differences between these two. So capmatinib is twice a day, tepotinib is once a day. Generally speaking, most common side effect we see with these MET inhibitors is edema, as well as increased creatinine, which we'll talk about more in a moment. Some other things to keep in mind and differences between these agents when you're deciding which ones to use. Tepotinib only has one dose reduction allowed, so you can dose reduce once, and then if the patient isn't tolerating that, the recommendation is to discontinue use. Capmatinib has multiple dose reduction options, so I do think that's a nice option despite it being a twice-a-day drug. The other thing to keep in mind is the half-life. So again, a shorter half-life with capmatinib, faster on-off switch, whereas we have a longer half-life with tepotinib. So just something to keep in mind if you are concerned about tolerance with these patients. So I mentioned we can see an increased creatinine with these agents. You can see a list there that is not comprehensive, but many of our TKIs in the lung space can cause what is called a pseudo-AKI. And that is due to inhibition of MATE and OCT, which are renal transporters that constitute tubular creatinine secretion pathways. So basically what happens is we see an elevated creatinine in the blood, which is not indicative of an actual change in renal function. So if we have a patient on one of these agents and we see an elevated creatinine, oftentimes we will grab a cystatin C. Cystatin C does not undergo secretion by renal transporters, so this is a good option to gauge whether or not the AKI is real or not. And then I won't be able to dive into these today, but just wanted to illustrate that that we have several new targeted agents that have come to market even just in the last couple of months. And I think that this is a trend that we are going to continue to see in non-small cell lung cancer. In terms of what else is next, so we saw a lot of immunotherapy shift to the perioperative space in the last few years, and targeted therapy is really following that trajectory as well. So we've had adjuvant targeted therapy added in the last few years, and now we're starting to see it used in the perioperative space, in the neoadjuvant space as well. Amivantamab, unfortunately, despite its toxicity, is not going anywhere. We are seeing it used in a variety of combinations in current trials. And again, we are still waiting for that sub-Q formulation to come out, which will reduce those infusion reactions. There are a lot of studies looking at combination TKIs to overcome a lot of emerging resistance mechanisms. We are also studying KRAS G12D and V inhibitors. Again, we currently only have G12C as a targeted option. Antibody drug conjugates have also worked their way into the non-small cell lung cancer space. And bispecific antibodies are also being studied, including ivonescimab, which is a dual PD-1 VEGF inhibitor. We do have some patients on this here at UW as well. So in conclusion, targeted therapies in non-small cell lung cancer are constantly growing and evolving. As demonstrated today, there are a lot of different drug interactions and toxicities, a lot of nuances between the different agents for a specific target. So please consult your pharmacist. And with that, thank you for tuning in. I know there was a lot more on the slides than what I was able to cover today, so please don't hesitate to reach out to me via email with questions. And I will hand it over to Mikala.
Mikala, it looks like you're still muted.
How's that? Is that any better?
Yeah. Yep. Sounds great.
All right. Thank you.
Yes.
I'll get this full screen. Okay.
Yeah. Looks perfect.
Appreciate it. My name is Mikala Hillis. I am the GU Oncology Clinic Pharmacist, and I'll be taking over to talk about GU targeted agents. So a quick overview of what we'll cover today. We'll be looking at the medications used in GU malignancies and some supportive care measures to help manage their toxicities. To start off, we'll go through prostate cancer targeted agents. The backbone of this class or disease state is the class of androgen deprivation therapy. These include both LHRH, luteinizing hormone releasing hormone, also known as GnRH, gonadotropin releasing hormone, agonists and antagonists. So the goal of both of these therapy types is to lower testosterone to castration levels, specifically with a goal of serum testosterone below 50 nanograms per deciliter after 1 month of therapy. A key difference between the two, of course, is that when the receptor is agonized, there is an increase in LH and therefore testosterone, which leads to what's known as testosterone flare. After that initial increase with continued stimulation, there's negative feedback to the hypothalamus, which reduces production of LH and suppresses testosterone ultimately. So agonists don't work as quickly, but do result in the same goal serum testosterone suppression at that 1 month mark. Here are some agents that we use in both classes. It's not a comprehensive list of agonists especially, but these are the most commonly seen in the world of prostate cancer. As you can see, there are different administration routes between intramuscular for our Lupron brand of Leuprolide, as well as multiple subcutaneous options, whether that is in the agonist or antagonist group. Ziguralex being that sub-Q antagonist. Uniquely, relugolix is an oral antagonist that exists. Both antagonists, as you'll note, do require a load. Relugolix would need to be reloaded if the patient is off therapy for a week or more. But switching between these two agents is something that we do for various reasons, whether that be patient tolerability or the initial need for an antagonist due to the goal of avoiding flare completely. As a class, these both agonists and antagonists have shared side effects, including hot flashes, fatigue, arthralgias, myalgias, sexual dysfunction, and even gynecomastia. In the long term, these patients should be monitored for bone loss, osteoporosis, as well as metabolic syndrome, obesity, and reduced muscle mass. It is actually recommended in the guidelines to run a FRAX score for each patient who is initiated on ADT, including that ADT plan as a risk factor to assess the need for bone modifying agents from a bone loss perspective. As noted here, there may be a difference between the antagonist and agonist when it comes to cardiac risk. This is primarily driven still by data from the HERO trial, which was a relugolix trial that showed lower incidence of cardiac events in patients on relugolix versus our agonists. And historically, we have seen some drug shortages of Lupron that have required exchanges to a preferred product of sub-Q Eligard. Currently, Lupron IM is our preferred UW product. And as you can imagine from a accessibility perspective, our oral agent relugolix, since it goes through the prescription drug plans for patients, may have different restrictions or higher out-of-pocket costs than some of our in-clinic administrations. Here's a little bit more about that tumor flare. So again, initial surge of LH and FSH can lead to that increased testosterone in the short term. This can promote more symptoms, particularly the ones that patients initially present with from their disease. Often that includes bone pain, urinary symptoms. This usually resolves clinically after about 2 weeks, but in order to prevent this, concurrent anti-androgen therapy is recommended. So in patients with overt metastases, particularly in weight-bearing bone, where a flare of these symptoms could be dangerous, it is recommended to have an anti-androgen on board in combination for at least 7 days. Usually we'll start these a week or two before an agonist and then continue them for a couple of weeks after. But 7 days is that minimum duration of overlap. Most commonly, we use bicalutamide, brand name Casodex, which is our preferred first-generation anti-androgen based on the toxicity profile. This is some more of that data about the cardiovascular risk, again, with the most recent being the HERO trial, but we have some other information that is more on a systematic review, meta-analysis, and retrospective plane that further reinforces that proactive finding. So again, major acute cardiac events were 4.8 times higher with leuprolide in the HERO trial in 2020 than with relugolix. So I'll let you dive into that more on a later time. As we evaluate this risk, we also consider our plans for future additional therapies. So in the event that we prefer to reduce overall cardiac risk, our agonist might not be the one we started initially, both again for flare reasons as well as cardiac reasons. But it could play into our choice of androgen receptor antagonists as well. So these targeted therapies are added to ADT, and they work by binding to the ligand binding domain of the androgen receptor. They inhibit androgen binding and therefore nuclear translocation and prevent the transcription of AR target genes. So these are inhibiting that mechanism by which androgens, including testosterone, are driving growth. To briefly expand more on the first generation antagonists, I mentioned that bicalutamide is our preferred option. As you can see, that's a once a day single pill 50 milligram versus some of the other options that may require a load or multiple time a day dosing. All of these are known to cause diarrhea and even have been associated with hematuria, but you'll note the list of adverse effects is shorter and even has some lower percentages when it comes to Casodex or bicalutamide, leading to our preference there. We can also see hepatitis, transient elevations in LFTs, as well as this eventual development of agonist versus antagonist activity with the stimulation of the androgen receptor. And this is something that's associated with that first generation group. So once again, if over time we're administering a first generation antagonist, we could see some agonist activity that leads to a PSA rise. And then upon stopping, we could see that PSA decline. Commonly now for treatment within our algorithms, we'll add second generation anti-androgens to the ADT. So apalutamide, darolutamide, and enzalutamide are some second generation options that we consider. You can see different dosing here as well as available tablet sizes. Of note, darolutamide is recommended twice a day versus the others are once a day and is to be administered with food. One thing I want to call out about this group is that they do have multiple drug interactions with some of our main drug metabolizing enzymes. So that includes CYP3A4, 2C8, and PGP. Some key players or concomitant medications that we screen for these interactions include statins, DOACs, clopidogrel, even calcium channel blockers, PPIs, citalopram. Darolutamide, the most common one that we need to adjust is rosuvastatin. This requires an empiric dose adjustment to a maximum of a 5 milligram dose. But across the board, you can see the adverse effects do vary a little bit between these three agents. Rash is more common with apalutamide as well as hypothyroidism. All can cause fatigue, but darolutamide less so, generally more well tolerated. It also has poor blood-brain barrier penetration. So we associate darolutamide with a much lower risk of seizures than apalutamide and enzalutamide, whose initial approval trials excluded patients who had a history of seizures, but we have since shown can increase seizure risk, particularly in those with a seizure history. Uniquely, darolutamide does require a renal dose adjustment. The other agent to talk about in this space is an androgen receptor pathway inhibitor, abiraterone. This inhibits CYP17, which is an enzyme required for that androgen biosynthesis, so it works a little upstream of those receptor inhibitors that we've discussed. It inhibits the formation of testosterone precursors, but in turn, it also lowers cortisol and leads to a compensatory increase in ACTH. So there is an accumulation of mineralocorticoid steroids. We use prednisone for its glucocorticoid activity to mitigate the effects of that mineralocorticoid excess. So the adverse effects that can happen in that imbalance are hypertension, hypokalemia, and fluid retention. And again, preventing these with prednisone is essential. We recommend different doses based on diagnosis, but sometimes prednisone does need to be adjusted or increased if these side effects are present despite 5 milligrams a day, for example. So that's called out a little bit here. The most common formulation of abiraterone that is prescribed is Zytiga. Most commonly, that is 4 250 milligram tablets for a 1,000 milligram dose once a day. This does also come in the 500 milligram version, but that's a little less accessible, a little more expensive. As I alluded to, the dose of prednisone depends on the disease state context. So in castration-sensitive disease, 5 milligrams once a day is used. In resistant disease, we automatically give twice a day based on symptom management needs and historic practice, as well as the way the studies were done in that space. If a patient with sensitive disease does exhibit signs of mineralocorticoid excess, we have a very low threshold to increase prednisone to twice a day for those as well. Zytiga does need to be taken on an empty stomach an hour before and 2 hours after any food. In contrast, the other formulation available is called Yansa. It's a micronized form. This is not commonly used, but the dosing is included here. It's still 4 pills all at the same time, but it's not used with respect to food. It can be with or without. And it's dosed with methylprednisolone, which is a twice-a-day regimen of steroid for everybody, but it's currently only indicated in the castration-resistant space. Adverse effects of this are similar to what we've seen before, such that it does include that list of mineralocorticoid effects, as well as some of the metabolic effects that we've mentioned monitoring for, such as hyperglycemia, hyperlipidemia. And this agent is associated with a higher risk of cardiac events. So once again, it may influence even our ADT choice if we know that our goal is to prescribe abiraterone for a patient, or it may lead us to choose a different ARPI, androgen receptor pathway inhibitor. If a patient has higher cardiac risk, we might avoid abiraterone. There is limited data to support the dose of abiraterone as 1 pill a day, 250 milligrams only, with a low-fat breakfast. If more fat is consumed, that increases the serum concentration of abiraterone more than 4 times. But with a low-fat meal, we know that it's about 4 times the concentration per dose. Once again, here reinforcing mineralocorticoid excess being one of our serious side effects that we monitor for, and that cardiac risk is important to evaluate prior to prescribing. The safety of this agent in patients with heart failure meeting these criteria is not established. And importantly, with abiraterone, there is a known risk of LFT rise, and we monitor those every 2 weeks for at least the first 3 months to monitor for that and adjust the dose as needed. This table gives a summary of where these agents are currently indicated. The expansion of darolutamide into the metastatic castration-sensitive space with or without docetaxel occurred around March of this year. The other things to call out is, once again, Yansa is not indicated in all the spaces, only in castration resistance. And the use with concurrent docetaxel currently is only FDA indicated for abiraterone and darolutamide, though the NCCN guidelines do recommend consideration or alternative options to combine enzalutamide and apalutamide in that space. And at present, the use of combinations with PARP inhibitors are recommended with abiraterone and enzalutamide, with the specific PARP inhibitors listed there, in the particular mutation settings described. Once again, I'll reiterate that drug interactions are a key consideration with this group. There are many, especially with those second generation androgen receptor antagonists. Patients with a significant cardiac history, not only do we recommend or consider avoiding abiraterone due to the risk of cardiac events, but we also need to check for their concomitant meds, because many of them are on the list of those medications that interact with the ARPIs themselves. And we watch for PPIs as well. So that's what I'm here to help with. Please contact me if you have questions about this. The other thing we consider with therapy selection in these patients is the financial toxicity. Medicare does have coverage for either the second generation anti-androgens or abiraterone. However, those brand name agents, those second generation anti-androgens, are limited as far as cost reduction options, as standard copay discount cards do require non-government plans, but those are available for patients with commercial insurance. As an alternative for anybody who's not able to afford the cost of the anti-androgens, the abiraterone generics are available in wider swaths of pharmacies, so even local or retail pharmacies will carry abiraterone, and these costs can be reduced using things like GoodRx. Patients with Costco memberships can have a membership price that's capped at about $140. And cost plus drugs also carries abiraterone. However, this is, as we know, an internet pharmacy that requires patients to be somewhat tech savvy. So other than that, we do pursue other medication assistance and grants for these patients. There are a number available in the prostate cancer space. So I mentioned that FRAX scoring and adding bone modifying agents for osteopenia and osteoporosis is recommended upfront with ADT. But in patients with bone metastasis, it's also important to consider in the castration resistance setting the use of bone modifying agents. The dosing for these is listed here. On label for Zometa, we're looking at 4 milligrams every 3 to 4 weeks. However, in the castration-resistant space with bone metastasis, there is data for dosing every 12 weeks. And this coincides nicely with the use of leuprolide. We commonly use that 3-month dosage form, 22.5 milligrams, and bring people back on that schedule regularly so we can align with this bone-modifying agent on that schedule. It is recommended to hold for hypocalcemia if corrected calcium is below 8.5. And there are renal dose adjustments required in creatinine clearance below 60. Adverse effects of Zometa can include a flu-like syndrome, hypocalcemia, and even osteonecrosis of the jaws that is a bisphosphonate. Denosumab is the other option. It's a RANKL inhibitor. This is indicated every 4 weeks at a dose of 120 milligrams for bone metastasis. Not only do we hold for hypocalcemia with this agent, but also hypomagnesemia and hypophosphatemia, although it does not require a dose adjustment. So in patients with significant renal dysfunction, it is perhaps a preferred option and can be used kind of as an exception per our formulary. Adverse effects, as you can imagine, lowering those electrolytes, and once again, ONJ. So I have a quick timeout. Make sure everybody's still awake and listening to us today. I have a patient, PT, 45-year-old male diagnosed with metastatic castration-sensitive prostate cancer with bone mets, including the fever, and we're planning to start ADT. What supportive therapy should be added? And I see a hand raised. Go ahead and speak up if you'd like.
Sorry, I did not mean to raise my hand.
Oh, do you have an answer to the question, or is that
But I
anyone
am
else?
paying attention.
Okay, great. So we have castration-sensitive prostate cancer with bone mets, and we're starting ADT.
Would want to give them bicalutamide before they get the ADT.
Yes, yep. So we have a met in weight-bearing bone, important to give bicalutamide, prevent the risk of flare and potential fracture with that. Also would want a FRAX score with starting ADT, checking for osteoporosis, osteopenia, and any bone loss indication to start those. Bone modifying agents. Later, we're going to start apalutamide. What is the most important thing that I harped on that we need to think about for apalutamide? I'm trying to drum up business for myself here. We need to check for drug interactions. So please come talk to your friendly pharmacist. And we'll talk about a monitoring plan for adverse effects like rash, hypothyroidism, as long as those classic anti-androgen effects and any comorbid medications we need to think about. All right. Our next targeted agent is Pluvicto, lutetium. This is a radionuclide, of lutetium-177 that is linked to a moiety that binds prostate-specific membrane antigen. After this binds, beta-minus emissions deliver radiation to those cells. So it's more local administration of that radiation, which results in DNA damage and cell death to those cancer cells as well as the microenvironment. Adverse effects of this can include electrolyte abnormalities, xerostomia, dry mouth, GI effects like constipation or diarrhea, myelosuppression, and then organ effects. So we can see increased AST, serum creatinine, and fatigue. Important counseling points for this are that patients are radioactive for a period of time following therapy. So there are different recommendations for keeping a distance, as well as avoiding long periods of time close to other people for a number of days. And with that, we'll move on to urothelial cancer. Our first targeted agent in this space is erdafitinib or Balversa. Initially, we start the dosing of this at 8 milligrams once a day. And then at 2 to 3 weeks after starting therapy, we assess the serum phosphate level. If that level is less than 9 and there aren't any evidence of ocular disorders or toxicities grade 2 or higher, we raise the dose to 9 milligrams once a day. This can be given with or without food, and it does have pan-fibroblast growth factor receptor inhibition. So we know that it inhibits FGFR1, 2, and 3. However, the indication is specific to FGFR3 based on the efficacy data. This is interesting to those of us in GU because initially when it was put on the market and approved with contingent approval, we had activity in 2 and 3. So we knew we could use it in either of those spaces, but later data showed that 3 is where the benefit is. So that's where that final FDA approval lies. Of course, as you can imagine, based on that dosing I described, we want to avoid use of concomitant agents that can raise serum phosphate levels, so vitamin D supplements, antacids, anything with phosphate in it, particularly in the beginning before we get that initial phosphate check. This medication also interacts with CYP2C9 interacting drugs as well as CYP3A4 interacting drugs. As far as adverse effects go, just reiterating once again that 76% of patients do have an increase in serum phosphate, and that usually happens around 20 days, which is the reason for that 2 to 3 week check. We can also see fatigue, hand-foot skin reaction, dry mouth, diarrhea. We also know specifically that ocular toxicities are something to monitor for with this agent. So that can include dry eyes, blurry vision, and even something as serious as retinal pigment epithelial detachment. So it is important that ocular exams are done. These are done at baseline, monthly for the first 4 months, and then every 3 months. And the PI even describes specifically what these need to include. So that would be like a visual acuity assessment, slit lamp examination, fundoscopy, and even optical coherence tomography are all specifically spelled out. Haley, did you have a question?
Yeah, I just I'm gonna actually be seeing somebody today who's starting erdafitinib for gastroesophageal cancer with METs.
Mhm.
So the dosing increase, that's for all patients that are receiving it, right?
That's the label dosing, yeah. So if they're tolerating it, if the level is less than 9, as far as phosphate goes, then we consider a dose increase.
Okay, thank you.
So the mechanism of this hyperphosphatemia is through FGFR inhibition in the renal proximal tubule, and that inhibits phosphate reabsorption. So I've got my fancy mechanism diagram up here in the upper right. It is covering my words a little bit. I'll fix that for next time. But on that initial phosphate check, if the level's under 7, but elevated, so 5.6 would be considered kind of above the upper limit of normal, you don't change the dose of erdafitinib, you continue at the current dose, and then you continue to monitor phosphate monthly, or if the patient's symptomatic, more often. 7 to under 9, we still continue the dose, but we do start a phosphate binder. And that should be taken with food until the phosphate level drops back below 7. If the level is persistently above 7 for 2 months, then we would lower the dose. Other side effects, other tolerability reasons would also lower the dose. At a level of 9 to 10 milligrams per deciliter for phosphate, we hold erdafitinib and increase our frequency of phosphate monitoring to weekly. When it becomes less than 7, we would reinitiate and maintain the same dose as long as we have a phosphate binder on board as well. If the level remains greater than 9 for a month, we would lower the dose. And at above 10, once again, we hold, assess weekly, manage any symptoms medically, of course. And then when the level is less than 7, we empirically lower the erdafitinib dose and reinitiate. If the level stays at 10 or higher for more than 2 weeks, erdafitinib should be discontinued. And this is all spelled out very specifically in the package insert. The next targeted agent to discuss is enfortumab. This is dosed IV, and it's 1.25 milligrams per kilogram with a maximum dose of 125 milligrams. So even if your patient weighs over 100 kilos, capped at 125. We give this days 1, 8, and 15 every 28 days when it's given as monotherapy. In combination with pembrolizumab, it's days 1 and 8 every 21. So they always get 1 week off kind of at the end of that cycle. This is an antibody-drug conjugate that targets Nectin-4 and is coupled with MMAE, which is a microtubule disruptor. Long name for that is monomethyl E. Adverse effects for this one, it does have low emetic potential and a low febrile neutropenia risk, but can cause rashes fairly commonly at about 55%. This most often happens in cycle 1, so like less than a whole month, into therapy. Grade 3 skin reactions can happen a little less commonly than your stereotypical rash, and those can appear as maculopapular rashes, pruritus, even exfoliation of the skin with photosensitivity, itching, and even like dermatitis bullous. We can see hand-foot skin reaction with this one as well. This is another agent that we monitor for ocular toxicity. That can happen fairly commonly. We do recommend over-the-counter eye drops for all of our patients who start this treatment, and it usually occurs within the first month and a half. We can see bone marrow suppression and low counts with enfortumab, so that is part of our kind of whole parameters for this treatment, as well as increased blood glucose and peripheral neuropathy. If patients do have persistent dry eye symptoms despite the use of artificial tears, we recommend consideration of steroid eye drops. So usually work with ophthalmology to give them regular exams and prescribe those. Importantly, if blood glucose is greater than 250, it is recommended to hold enfortumab until improved. Of course, blood sugar control, we have a lot of ways we can help manage that. So it is okay to resume enfortumab at the same dose, even if a patient has had an episode of hyperglycemia and required a dose hold. Another reason that we hold enfortumab is in the setting of liver dysfunction. So if total bilirubin is greater than 1.5 times the upper limit of normal with any AST, it's recommended to avoid enfortumab use. Here's a little bit more about that rash that we can see. So again, it targets Nectin-4, which is also expressed in the skin. This can impair that cell adhesion and lead to epidermal detachment, so some of that bullous presentation. And further, MMA itself causes skin irritation and toxicities. And so once again, maculopapular rash and pruritus, red, scaly, pruritic papules, predominantly in the skin folds, or like I mentioned, the hands and feet at about the 1 month mark or sooner. To prevent the rash, we recommend patients use sunscreen, using barrier agents in the skin folds, so zinc-containing moisturizers, as well as moisturizing all skin, especially areas exposed to sun or friction, at least once a day. Avoiding harsh temperatures, so hot water, any fragrance products, drying agents, and doing self-exams as well as having physicians assess any suspicious areas of the skin prior to each treatment as kind of a regular part of the follow-up. To treat the rashes, we start with topical steroids as well as potentially topical antibiotics, taking antihistamines for any itching. And if the rash is grade 2, it is recommended to consider oral antibiotics. If a grade 3 rash is identified, we hold that treatment until it is resolved to grade 1 or better. We can consider reducing a dose for this or resume at the same level, depending on the goals of therapy and the tolerability of potential recurrence from the patient's perspective. And we may even start oral steroids at grade 3, as well as considering talking to dermatology. If the rash recurs, we would stop the treatment. May need inpatient management, especially if it's grade 4, and definitely a derm consult and a biopsy if we suspect SJS or TEN. So these rashes can be quite severe, so we try to monitor for them closely, catch early, and manage with topicals as best as we can. And that brings us to our next pause here. We have a patient with urothelial cancer who progressed on EV Pembro. What testing would we want to identify an oral therapy, and what do we need to think about as baseline eval for that treatment? Oral targeted therapy that I talked about.
You can send NGS for like an FGFR mutation.
Right, looking for that FGFR3. Baseline evals would be Vision
Like
exams.
phosphate and eye exams.
Yes, you got it. And then we need to check them at least monthly, both for the eyes and the labs. Thanks so much. All right, RCC to round us out. So RCC is not a very chemosensitive disease, so our targets primarily are VEGF and our immunotherapies. Initially, our VEGF inhibitors were sunitinib. That one was a 4 weeks on, 2 weeks off dosing schedule that targeted PDGFR, as well as some other FLT3, RET, and importantly, VEGF. It is a CYP3A4 substrate and has some notable toxicities, including hand-foot skin reaction, fatigue, and mucositis. I am speaking in tense because even though it's still in the guidelines, it's not very well tolerated. It's not used very often, but you might see even in other tumor types a continuous dosing scheme, for example, in peanut and GIST. Pazopanib is another of the older TKIs, but we do sometimes use this in certain specific cases. It's dosed at once a day, 800 milligrams, which is 4 of the 200 milligram tablets. It does need to be on an empty stomach, and importantly, has interactions with acid suppression. So H2RAs and PPIs are not recommended with this therapy. It can cause side effects including diarrhea, liver toxicity, and stomach pain. And once again, it's not well tolerated, but we can sort of adjust the dose. And for people who meet criteria such that they can't tolerate any of our other preferred options, this once-a-day TKI does present a possibility. More commonly now, we would use cabozantinib or Inlyta axitinib, as well as lenvatinib or tivozanib, which we'll get to on the next slide. Cabo is a once-a-day agent. When we use it as a single agent at 60 milligrams, but in combo with nivolumab, we use it at 40 milligrams. This one also needs to be taken on an empty stomach with the same rules, 1 hour before and 2 hours after food. You can see its targets there. It is a major CYP3A4 substrate, so once again, consideration for drug interactions. Most common side effects of this one are fatigue, hand-foot skin reaction, and increased blood pressure. Its half-life is 99 hours, so for patients who need a procedure, if it's planned, the recommendation is to hold for 3 weeks prior to surgery. This is due to the effects of VEGF targeting agents on wound healing, bleeding and clotting risks, and so on. Inlyta, on the other hand, 5 milligrams twice a day. Not super common to increase, but can be increased if tolerated to 7 twice a day and even up to 10 twice a day. This can be taken with or without food and is a little bit more selective. You can see the side effects there that are most common are about the same as some of the other TKIs we've seen: hypertension, fatigue, and diarrhea, as well as that hand-foot skin reaction. We start in the middle of the dosing range for this. Again, many patients stay at 5 or require a reduction. And the half-life of this is much shorter, 2.5 to 6 hours. So we consider this agent for patients that we may have tolerability concerns in, or who may have a number of planned procedures upcoming, because we can take it off and on more quickly, as well as the fact that it's more selective. It may be better tolerated. Here are the other two as promised. So lenvatinib can be combined with everolimus or pembrolizumab. As you note, it's different dosing in those two settings. This comes in a dose pack with cards that specifically show the patient what pills to take each day because, for example, the 18 milligram dose is made up of a 10 and 2 4s. It does require dose adjustment in both renal and hepatic function, can be taken with or without food, and targets a number of FGFR and VEGF receptors. It's a minor CYP3A4 substrate, so less significant drug interactions with CYP3A4 interacting meds. And again, you see the classic side effects listed there, more commonly hypertension, fatigue, and arthralgias, myalgias with lenvatinib. The half-life of this one is 28 hours, so once again, hold required prior to surgery of at least 1 week. Tivozanib is the last of the more common, newer TKI agents that it does require a hold of 1 week per cycle. So it's dosed on days 1 through 21 of a 28-day cycle. Again, hepatic considerations here, more selective, so focus on just VEGF 1, 2, and 3 receptors. Major CYP3A4, so we can see interactions there. And again, fatigue, hypertension, and diarrhea being the most common side effects. It has a lower risk of skin reactions than some of the others that we've talked about. And it is similar to axitinib in its receptor affinity, but there has to be a failure of 2 prior lines of treatment before tivozanib will be used, just based on how the study was done and coverage and insurance approval. Longer half-life here as well, 111 hours, so 24-day hold prior to surgery is required. Here are the combinations that we commonly see. These are kind of our first line combinations: immunotherapy plus VEGF. VEGF inhibits both innate and adaptive immune system, upregulates the expression of PD-1 and CTLA-4. So that leads to sort of a synergy or a collaborative effect of these 2 agents. Many people do require lenvatinib dose reductions from that 20 milligram starting dose. So the median tolerated dose is about 14 milligrams. Some of our providers, once again, prefer axitinib in the tolerability concern population because of that selectivity and shorter half-life. I've already pretty much summarized these class effects, but in a serious toxicity list, we need to remember that gastrointestinal perforations as well as thrombotic events can occur with these agents. Of course, we've got those considerations for wound healing. Proteinuria is something we monitor for regularly with each visit, and we may need to hold or dose adjust, as well as a hypertension and hand-foot skin reaction. Hypertension, median onset is about a month, but it can happen as early as within 2 weeks. Risk factors are listed here: increased BMI, older age, or underlying hypertension. If patients have risk factors, we recommend that they track their blood pressure at home once a day. We start therapy, antihypertensives, if their blood pressure is greater than 140/90. Usually we begin with a calcium channel blocker just on the mechanism that's driving this with our VEGF inhibitors. And we hold if their blood pressure is above 160/100, or if we're not able to get control with antihypertensives. Second line, as listed here, ACE or ARBs. And we do need to watch the proteinuria with these due to kind of overlapping side effects. If patients are having proteinuria from a VEGF inhibitor, we would want to note that in the setting of adding an ACE or an ARB. Hand-foot skin reactions described here. So in the space of these VEGF TKIs, it's hyperkeratotic lesions on the hands and feet. Sometimes they burn, feel funny, is what patients tell me, or present as callus-like blisters, dry cracked skin. Usually this happens within 2 to 4 weeks. Again, prevention is key with this, but options to do that include unscented moisturizers, gentle exfoliation, and avoiding friction, harsh temperatures, wearing thick cotton gloves or socks at night. Treatment is described here. So again, with grade 1, we're looking at more over-the-counter and topical management, even cold packs for relief, maybe prescription topical steroid of a moderate potency. Grade 2, we definitely need that prescription strength steroid, and then pain relief. And grade 3, we hold treatment for at least 7 days or until improvement, and we may use topical antibiotics as well as additional pain medication. I'm going to skip this for time. Belzutifan is our last agent. So this, not last, second to last, excuse me. We've got HIF2 alpha targeting mechanism with belzutifan. So this small molecule inhibitor stops hypoxia-inducible factor 2 alpha, which can accumulate in von Hippel-Lindau-driven malignancies. So this can be patients with a VHL diagnosis, or for patients whose RCC is driven due to VHL processes and dysregulation. As we inhibit this, we decrease gene transcription and lead to reduced erythropoietin production and iron metabolism, preventing the oxygen sensitizing and regulating genes. So again, inhibiting the growth of cancer that is a result of dysregulated oxygenation processes, but that leads to adverse effects, including commonly anemia, even hypoxia. The median onset time of anemia is 31 days, so about a month, and the recommendations are to hold if hemoglobin is less than 8 or if transfusion is indicated. Once the hemoglobin is above 8, we can resume a reduced dose, or if it was very severe, we might permanently discontinue. A reduced dose would be from our initial 120 dose of 3 tablets once a day down to 180. Down to 80, excuse me, 2 tablets once a day. All right, and this is the last agent. So everolimus, mTOR inhibitor, it is metabolized hepatically. So once again, CYP3A4, it is a major substrate, so can have drug interactions there. It is used, as I mentioned, most commonly in combination with lenvatinib, and because of some of the cumulative side effects, we watch extra closely for mouth sores, wound healing concerns, as well as kind of that hand-foot syndrome and rash picture. The SWISH study is extrapolated to the renal cell space. This was initially one done in breast cancer world, but we use it to recommend a proactive dexamethasone mouth rinse for patients taking everolimus and lenvatinib. And that's it. Thank you so much for listening today. You can reach out to me by email if you have more questions.
Yeah, there was one question in the chat.